Hello and welcome to the NESERA Clinical Education and Medical Specialties podcast, formerly the Clinical Care Options podcast. I'm your host, Zachary Schwartz. This is the third of 3 episodes from our live event, Raising the Bar, Innovations in PBC. In this third episode, Dr. Aparna Goel explores why management of symptoms such as pruritus and fatigue should be considered independently of biochemical response and how new therapeutic agents can help. She then explores a case study and questions from the live audience. It's a great discussion between Dr. Goel and her co-faculty, Dr. Chris Bowlus and Dr. Alia Ghulam-Hussain. To follow along with the slides, visit the show notes. Now let's start things off with Dr. Goel.
So my goal is to talk about how we can do a better job addressing symptom management in our patients with PBC. So just a reminder, the 2 big symptoms that we think about are pruritus and fatigue. We'll focus on pruritus first. Pruritus, cholestatic itch, is incredibly highly prevalent in people living with PBC. It affects up to 81% of people. Up to 40% of our patients say that they have had no discussion regarding their itch with their healthcare providers. So we're under-evaluating it in practice. A lot of the times there's a disconnect between the severity that's reported by our providers and by patients. So it's often underappreciated, and the concordance rate is only 70%. And up to 33% people living with itch say that they have never received treatment for it. So we can do better. That all goes to say we can do a better job treating itch in our patients with PBC. So when someone with PBC describes mild itch symptoms, we'll often talk about using non-pharmacologic therapy first. And there's a host here that you can think about: topical moisturizers, discouraging hot showers, so using cooler showers, hypoallergenic laundry detergents and soaps, avoiding irritating factors, and then cognitive behavioral therapy has shown to be beneficial as well. A reminder that while ursodeoxycholic acid is first-line treatment for PBC, for disease modification itself, it does not impact pruritus. So the pruritus needs to be addressed separately and needs to be treated independently of PBC. The mechanisms in which pruritus happen in people living with PBC is quite complex. We know that bile acids and pruritogens are implicated in the process, and that there's sensory receptors on the peripheral nervous system that are likely activated on the skin. So that's the MRGPRX4 protein that's on peripheral nervous system there. And then we also know that lysophosphatidic acid, or LPA, is likely an important activating factor for some of these ion channels that induce itch on our skin. Autotaxin A is the one factor that has been strongly linked to cholestatic pruritus, and ATX, or autotaxin, is one of the rate-limiting effects for the production of lysophosphatidic acid, so LPA. So there are some correlations that do exist. We know that we can modulate some of these things with our therapy, and there's various treatments that we have experimented with and used in our patients with PBC, and hopefully some of the second-line therapy will address the pruritus in some of these patients as well. So the list of medications that have been used in PBC pruritus is long. The only approved medication for cholestatic pruritus is cholestyramine, which is a bile acid binding resin. It is poorly tolerated by many of our patients and often causes constipation, fatigue, bloating, and retention is probably less than 15% for cholestyramine. A pruritogen reducer like rifampin is commonly used and can be quite effective. Modulation of central itch and pain pathways with naltrexone or sertraline or butorphanol can be quite effective as well. IBATs, or ileal bile acid transport inhibitors, have been studied for PBC and itch and for other cholestatic itch, and have shown that in people living with moderate to severe itch, it could be quite beneficial, and more to come with some of those ongoing studies. We've discussed, and we'll discuss a little bit more the data on some of the PPARs and their impact on itch, and then there's sort of salvage therapies that we think about as well, with phototherapy and plasmapheresis, and very rarely thinking about liver transplant when the pruritus is quite severe. So let's talk a little bit about the PPARs and what have been used, and we'll talk first about Bezafibrate. So Dr. Bowlus had reviewed the data for Bezafibrate in terms of efficacy for alkaline phosphatase improvement. When you look at people that are enrolled in the trial that had higher itch, and you evaluate their itch intensity scores, you can see that the group of patients that were treated with Bezafibrate and ursodeoxycholic acid had an improvement in their itch scores on a visual analog scale. That's the graph in blue up here at 24 weeks. So compared to placebo, there was an improvement in itch. And then separately, the fibrates and itch trial, so the FITCH trial, evaluated Bezafibrate in several different cholestatic conditions, PBC, PSC, and secondary sclerosing cholangitis, and enrolled patients that had moderate to severe pruritus. And you can tell that in the group that with PBC, that there was a significant reduction at 50%, over 55% of patients had over a 50% reduction in their VAS score compared to the placebo group. So there was a notable improvement in itch with Bezafibrate. What about in the Elative trial with Elafibranor? So we again discussed already the results that Elafibranor has in terms of statistically significant improvement in alkaline phosphatase levels and alk phos normalization. How did it do with itch? Well, the itch was evaluated in several different methods in these trials. So there's the worst itch NRS score, and then separately, all of our patients that were enrolled in this trial completed the PBC-40 survey, and they also completed a 5D itch score. So when you look at what is validated with cholestatic pruritus with the worst itch NRS score, there was actually not a statistically significant difference in the control of itch between the Elafibranor and placebo groups. But when you look at some of the other scores that were used to analyze itch with PBC-40 and with the 5D itch score, you can see that there was an improvement in the Elafibranor group compared to what the placebo group saw. So while it didn't meet statistical significance with the worst itch NRS, I think more to come to see if there are longer-term improvements or other improvements with itch with Elafibranor. So just to summarize with Elafibranor, we saw significant improvement in biochemical response in alkaline phosphatase levels, and we saw that there was a numerical improvement that wasn't statistically significant in itch. So how about with Seladelpar? So in the response trial, if you look at the patients with PBC that had moderate to severe pruritus, defined as an NRS score greater than 4 that were enrolled in the trial, we do see that at the end of the trial, there was a significant difference in those treated with Seladelpar compared to the placebo arm up here. So there was a significant improvement in itch as defined by the worst itch NRS score. There's also been data presented on how Seladelpar changes levels of interleukin-31, which we know has been implicated with cholestatic pruritus. And you can see that there is a reduction in IL-31 levels compared to baseline at month 3 in those that are treated in Seladelpar, and there was no reduction or no improvement in IL-31 levels. So the postulation is that perhaps Seladelpar modulates IL-31 and the production of IL-31, which can potentially reduce cholestatic pruritus. So just a summary of Seladelpar from the presentation so far. Significant improvement was noted in biochemical response and ALP, and a significant improvement was noted in itch. All right, investigational agents for PBC pruritus. So what happens if you have used a second-line therapy like Seladelpar in someone that is experiencing itch that needs additional control of their PBC, yet they continue to suffer from itch? What else can we potentially provide them? The IBAT inhibitors are being studied for the treatment of pruritus and PBC. So the Vantage trial was an investigational Volixibat trial studying pruritus changes through week 28. This was a phase 2 study. And you can see the Volixibat was studied in 2 doses up here, both 20 milligrams and 80 milligrams doses up here. And at week 28, you can see that there's a significant difference in itch scores and the adult itch ROSE scores in the Volixibat treated group compared to the placebo treated group. So it gives a signal that potentially another mechanism for which we could control cholestatic pruritus and PBC is with the depletion of the bile acids. And then similarly, the GLISTEN trial was a phase 3 study of Linerixibat in people with PBC that had moderate to severe pruritus, and they were treated with Linerixibat for 24 weeks. And in this study, you can see up here that the curves separate really nicely, quite early on actually. And at week 24, you see that there is a significant improvement in itch in those that were treated with Linerixibat compared to the placebo arm. The study is interesting that there was a crossover after, and you can see that when patients were taken off the Linerixibat, you can see that there was, again, an increase in their itch, and then separately, the placebo group that was crossed over to Linerixibat had an improvement in their itch score. So it really does help lead credence to potentially treating severe cholestatic pruritus with IBAT inhibitors. We'll switch gears now to talk about fatigue. So fatigue and PBC, again, quite prevalent, affecting up to 78% of people living with PBC. We know that the pruritus, we know causes sleep disturbances. Fatigue can be separate from that. The fatigue is also worsened with obeticholic acid, and we know that it is not improved with ursodeoxycholic acid. And when we discuss the impact of fatigue with our patients, it's really hard, I think, in a 15, 20-minute visit to quite understand how big of an impact it can have on their quality of life and what you can do to sort of address it with them. But it is something that we should be asking about. Unfortunately, how we can treat it, it remains, I think there's a lot of study that we can do and a lot of improvement there. So how and why does fatigue happen in cholestatic liver disease and especially in PBC? The short answer is we're not really sure. There's a lot of different theories and a lot of different confounding variables that likely are contributing to the significant fatigue and the brain fog that our patients are experiencing. We know that this is an inflammatory process, so likely inflammation is triggering the fatigue as well. The cholestasis likely contributes. There's concomitant psychologic factors and mental health comorbidities that go along and sort of go hand in hand with having bad quality of life, including depression, anxiety, impaired cognition, and the worry about the future. We see that many of our patients end up socially isolating because of their quality of life, the impact that pruritus has on their skin or the clothing that they're wearing, or the impact that fatigue has on their desire to go out and have dinner with a friend. So the social isolation likely contributes to it as well. We also know that there's neuropathic factors at play. The central nervous system is involved in some way. The peripheral muscular system we know is likely involved in that there's differences with impaired relaxation of both motor neurons and sensory neurons, and it can play a role. So there's multiple mechanisms at play, and how to address them, I think, is a really big challenge. So what can we do? We obviously educate and validate their symptoms and understand that this is part of their disease. And I think that a lot of the times they just need to hear that. They need to hear that it's not in their heads, that the people around them might not see it because they might look completely healthy, but they need to have their symptoms validated and kind of recognize that this is likely related to their PBC, as long as you've excluded other causes as well. We do encourage regular physical activity, obviously timing that physical activity to patterns during their day or during their week when they tend to have less fatigue. We talk about pacing strategies and task management. So, don't schedule things when in the middle of the day or at the end of the day, you're going to be quite fatigued or quite tired, or after a weekend when you're running after your kids, try to make that Monday or Tuesday really light for you. So really talking about that task management. Many of our patients with PBC do have mental health providers, therapists, or psychiatrists that help with psychologic interventions, including both CBT and ACT. And we talk about mind-body therapies as well. There's been a slew of medications that have been unsuccessfully tried in PBC fatigue. So modafinil was studied for 12 weeks. It was safe, but it didn't result in any sort of beneficial effects on fatigue compared to placebo. Rituximab was also studied and to see the improvement in fatigue over a 12-month study period, and again did not show effectiveness at treating PBC-related fatigue. SSRIs, including fluoxetine, did not show an improvement in the fatigue specifically, and there was some concern about drug-related adverse events. And then separately, a host of antioxidants have demonstrated safety, but no other real benefit in terms of fatigue. Let's talk a little bit about how these medications that are approved for second-line therapy for PBC control, how they have, if they have an influence on fatigue now. So again, in the Elafibranor study, there was a subgroup analysis of participants that had moderate to severe fatigue at baseline that was defined, again, in two different ways. It was defined either using the PROMIS fatigue short form or the PBC-40 fatigue domain. And when you look at the participants that were enrolled in the Elafibranor arm that had moderate to severe fatigue compared to the placebo arm, they showed benefit. The patients treated with Elafibranor had an improvement in their fatigue using the PROMIS score compared to placebo. Similarly, when you look at the PBC-40 fatigue domain, the participants that were treated with Elafibranor had a 39.6% improvement in fatigue compared to 26% in the placebo arm. So potentially lending some really good signals that the fatigue may be modulated with Elafibranor, and something to take into consideration when we're selecting second-line therapy for our patients. I think the natural next question is, well, did the fatigue get better because you controlled the itch better? So the pruritus gets better potentially with your second-line therapy, and is that why the fatigue is getting better? You're not itching at nighttime, you're able to get better quality of sleep, and you're not tired in the morning. So this was looked at with all the possible permutations you can imagine, using the fatigue domains and using the itch domains. and looking at the entire cohort of the study and also looking at just the folks treated with Elafibranor. And what the study investigators found is that there was actually no correlation. So in every permutation that you looked at, there was a very weak correlation between the fatigue and the pruritus. So the impact that Elafibranor had on fatigue is independent of the pruritus impact. What about with Seladelpar? Well, in the open label phase 2 study, you was looking at patient-reported outcomes, and this included patients that were treated with both Seladelpar 5 and then 10 milligrams, and then also 10 milligram group. The blue represents the patients that had an improvement in the fatigue, and the red represents worsening of fatigue. You can see that there were more patients that potentially had an improvement in fatigue, but I think more to learn about the fatigue impact with Seladelpar still. There are investigational agents as well. So Dr. Bowlus had mentioned the NOX1/4 inhibitor, Setanaxib. Setanaxib at a dose of 400 milligrams given twice a day did show that there were reductions in fatigue looking at the PBC-40 fatigue domain. So I think these studies or these results, the last few with the second-line therapies with the NOX1/4 inhibitors, do give us some hope that some of these therapies may also not only modulate the disease activity, but may also influence some of these extrahepatic symptoms that our patients suffer from with PBC. So just to summarize, a summary of PBC symptom management. Remember that symptoms, pruritus and fatigue, need to be treated independently of the PBC itself. Biochemical response itself does not correlate with an improvement in pruritus and fatigue. We see that, especially in the IBAT trials, that people had a good biochemical response, but still did suffer from moderate to severe itch. And don't dismiss the symptoms that people bring in because they've normalized it. So if they say, I'm okay, it's not that bad, I can deal with it, really, really do question what their symptoms, how their symptoms are affecting their quality of life and what you can possibly give them to make them feel better. Reminder that UDCA does not improve symptoms. Obeticholic acid may worsen symptoms, and PPAR agonists may improve symptoms as well. Well, briefly, with the last few minutes that we have, I'm sure that there's questions that we can answer from the audience as well. We'll briefly review a case now to help us understand how to manage pruritus in a real-world setting. So this is a 71-year-old woman who has PBC, who's referred to you for pruritus. Her medical history includes celiac disease, and she's compliant with a gluten-free diet, and she also has ITP. Her history of present illness, she was diagnosed with PBC at the age of 56, so she's been living with this disease now for 15 years. She has severe pruritus with an NRS score of 10, and you've given her all these treatments listed over here. So she's on cholestyramine, rifampin, sertraline, and gabapentin. And despite all this therapy, she has ongoing pruritus with an NRS score between 5 to 6, and she remains on ursodeoxycholic therapy. Her laboratory values indicate that she has an alkaline phosphatase level that's elevated but less than 200, and her GGT value is elevated. Her bilirubin is 0.9. Her ultrasound shows mild nodularity in a normal biliary tree, and her liver stiffness is 6.9 kilopascals. So we'll move to our panel discussion now. So for this patient, what would you do next?
Okay, so it seems like pruritus is a really hot topic. So this is exciting to talk about, I think. I mean, her liver tests aren't completely normal, right? She's 71, her liver stiffness is low, but I think this is the kind of person that despite what regulatory endpoints are, that you would want to push to treatment for symptom benefit and normalization of liver tests. So for this patient, I would probably pick Seladelpar up front.
Chris, what would you do?
Yeah, I think the same. I think that, given the results of the trials, the balance kind of tips towards Seladelpar in this case in terms of trying to address the pruritus. I think, one of the concerns is she's going to get better with the pruritus to some degree, but even with these PPAR agonists, if she's got moderate to severe pruritus, we aren't going to expect it to get completely resolved in most of these patients. They'll get a tremendous improvement and they'll express that, but I think going forward, the question is, she's going to have continued pruritus if we have an IBAT, or do we use off-label IBAT in these settings, right?
Right. I mean, this is walking into a lot of really excellent questions that come up. So why don't we go through some of them? One that I thought was interesting, it says, there seems to be one PPAR that talks about fatigue more and one PPAR that talks about pruritus more. Why is that? What do we make of that data, and how do we use that when we're informing decisions in the real world?
Yeah, I think we have a lot to learn still as these drugs are used for longer periods of time, and as we get more real-world data. The way that the analysis has been sort of provided with these phase 3 results is these were secondary endpoints and exploratory endpoints. So what is being reported is what was interesting in the studies, is kind of the way that I see it, right? So there was an improvement on some of these itch scores, but not the main one that they were looking at. We didn't necessarily see an improvement in fatigue overall, but like here's a bar graph that shows that there was some improvement in fatigue with Seladelpar. So I think that the statistical significance, I think, remains to be determined as we get a larger number of patients treated with these, and as we start to use them more, and as these patients are followed in the open label extensions. But in practice, I am taking the available data into consideration. So in somebody that does have significant fatigue, I am tending to use Seladelpar more. And in someone that is experiencing fatigue more, I am talking to them about Elafibranor more.
Yeah, it's hard, right? Like the PBC is an uncommon rare disease, right? It's not, the numbers in the studies are not huge. And then when you start to sort of siphon them off into subgroups, it becomes hard to take a ton away from it. But I agree with that approach. That's kind of what I'm doing as well. Another really good question that I'm not sure we're going to be able to answer, but what about patients with normal liver tests? Treatment response to URSO with normal liver tests. Should we use PPARs in those patients for pruritus?
We had this discussion.
Yeah.
and I'm a bit of a skeptic. I think itches, symptoms are hard because they are symptoms. So itch in particular is a very common symptom. And so just because someone with PBC has itch doesn't mean that their itch is coming from PBC. Mm-hmm. And I think that a patient that has normal alkaline phosphatase, and we talked about this before, normal serum bile acids, I would be looking for other causes of itch,
right.
Honestly. If we could measure IL-31, that would be great, because then I would feel more confident that it's not cholestasis that's causing her itch, or the itch. But I would be investigating other causes.
Yeah, I mean, I think I agree too, but I also acknowledge that, in about at least 50% of patients respond well to URSO, right? Mm-hmm. I mean, the proportion that have incomplete responses to URSO, the numbers in the literature vary, but somewhere maybe 30 to 50% depending on the criteria you use. But there are patients with PBC that we know that have normal liver tests with itch, right? I think we don't have the data that PPAR, I agree you have to rule out other causes of pruritus for sure, but today we don't have the data for pruritus in normal liver tests with a PPAR, right? Those patients just weren't included in these studies. Aparna, what do you think about IBATs in those?
Yeah, I think my approach would be very similar. Rule everything else out, but ruling everything else out means I'm also checking the serum bile acids. So if the serum bile acids are elevated, then I would consider an IBAT inhibitor in someone like...
Provocative.
Yeah, someone like this person, because if they are really elevated, then you have to think about, ruling out other intrahepatic cholestasis diseases as well, but depending on the degree of elevation. But this is somebody that then I would consider either off-label use or maybe soon something that would be available, an IBAT inhibitor for ongoing pruritus despite disease control, that is cholestatic pruritus.
Okay, symptoms. Is there a correlation between peri and post-menopause associated fatigue and PBC-associated fatigue in women? Hard.
Yeah, that's a really, really good question. I recently was at this other patient forum where I listened to a gynecologist talk about fatigue associated with autoimmune hepatitis and talking about assessing for perimenopause. There's no guidelines to help us in this area at all, but I think it is important that it be considered, and anyone that is over the age of 40 that is experiencing fatigue, a woman over the age of 40 that is experiencing fatigue, there should be an evaluation for whether or not there might be perimenopausal symptoms, and having a discussion about, and if those symptoms are potentially contributing to fatigue as well, they can be addressed in a discussion about hormone replacement therapy to see if there is an improvement in fatigue is something that should be on the table, was sort of my takeaway from this discussion.
I think just like any of our patients that have fatigue, we want to rule out other causes, right? Anemia, thyroid, et cetera. But the cause of fatigue in PBC is not because it's women that are perimenopausal or menopausal. I mean, it's not that. It is, a biologic response to the disease that we see in other inflammatory diseases. And if you listen to their symptoms, it's very similar to long COVID, which is a real thing, right? I mean, you have a clearly defined event, and after the event is resolved, you still have ongoing fatigue. And you see it in rheumatoid arthritis and everything else. So it's a real thing.
Yeah, and I mean, there could be additional reasons for fatigue beyond the PBC, but I think you're right. PBC is the fatigue, brain fog, sort of battery depleted symptom that people talk about is independent of those things. There's questions about the confidence in the fatigue data versus the pruritus data, and it's hard, right? There's many patient-reported outcome scores that have been used across these studies, and I think you have to sort of take away what the key secondary endpoints were, and for itch, that was mostly the NRS, right? What do you guys feel about the confidence in symptom benefit from a pruritus standpoint versus a fatigue standpoint?
So regarding the pruritus, I think it's a good point, right? So the NRS, the numeric rating scale, what it is that you ask the patient, what was your worst itch in the last 7 days on a scale of 0 being no itch and 10 being the worst itch imaginable. And then if you're 4 or greater, you're considered moderate to severe. And those are the people that are being analyzed.
Right.
The other things like the 5D itch and PBC-40 are asking more about what the impact of itch is and a little more descriptive of what the itch is, right? Because the severity of it doesn't really capture all of the parts of itch. So the NRS is just nice because it's a single value and you can do nice statistics on it, but it doesn't really capture everything. So I think, in clinical practice, the important thing is to talk to your patient. And, I do ask the NRS now because I want to gauge how severe it is. But it's interesting, then you talk about medication, and a lot of times that tells you how severe it is for them, because if they don't want to start a treatment, then I guess it's not as bad as opposed to if they actually do want to take a new medication for it.
I agree. I don't think that there is a one way to ask patients, but I think it needs to be addressed. Our level of confidence is as good as an N of, 30, 40 people that had moderate to severe pruritus, I think, in these trials. So it's not a lot of patients that we have data for yet. I think that we will learn more over the next year, 2, 3 years to understand what the larger impact is. I think anecdotally, we have seen patients that are on Seladelpar or on a PPAR that have an improvement in itch. So I do think that the data is not necessarily unbelievable. You do see patients improve on the PPARs.
And I mean, we have a lot of data with Bezafibrate, right? So I think the itch data is real. I think what is really important is that we objectively document, right, and follow patients over time. So the NRS is handy to use in the clinic. It doesn't take a ton of time, and you can really see patients improve or not for yourself. A PBC-40 will never be used in my clinic. It's not practical, right? It's just it takes too much time, and it's not practical, but maybe shows some impact in patient function that's different to what NRS captures.
I think one of the other ways we've assessed impact of the PPARs on itch is seeing what other medications they've been able to come off of. So there's some patients we start on second-line therapy, and kind of like this last case we had, they're off of all of the other antipyretic agents within 3 months. So they're not within a month. They're not taking cholestyramine anymore. They're off their sertraline, gabapentin. They've been able to actually stop everything because their pruritus is controlled. So just another way to sort of gauge if the itch has gotten better.
I think what you were saying is really nice. That as a class, I think we can say pretty confidently that PPAR agonists are improve itch.
Right.
And I think we can, whether one's better than the other, this, that, the other, we can, argue and discuss. But in general, they improve itch. I think what's really going to be interesting going forward is what is their impact on fatigue. And is that something we're going to see? And as we learn more, describe that. Because right now, that's the thing that, and to me in clinic, that's the most challenging. The itch is challenging, but we have some things to offer. The fatigue is the one where you say, well, just, arrange your schedule, do this, do that. But it's just really unsatisfying to really help our patients. So if there's really an effect there, I think that will be real improvement in our care.
That was planted. So the next really good question is, how do you measure fatigue in your practice?
That's a hard one. I don't use any scales. It's so impractical to ask patients to fill out scales to measure fatigue. What I will ask them is, did you cancel plans with friends, or did you take time off of work? Those are the two questions I tend to ask because of the fatigue, because you were so tired you couldn't go to work. You were so tired you had to cancel plans that you had.
Yeah, it's really hard. I mean, I'm intentional about ruling out secondary causes, right? Celiac disease, anemia, hypothyroidism, sleep apnea. I really do that intentionally. We talk a lot about mindfulness and things like that to intervene, but I almost even sometimes use 1 to 10 scores in terms of severity and impact, just to have something objective that's quick and practical. But you're right, to the person who posed the question, there's nothing at the bedside that's really easy to use, at least that I've found.
To me, on the fatigue side, it's more about having them describe it, because I don't have anything to offer them necessarily other than listening, and just letting them describe it and express how it impacts their life, I think, is somewhat therapeutic. So
asking and validating
just
is
asking
helpful.
and make sure
There are a lot more psychologists that are starting to get involved with CBT and ACT, so the acceptance training, and I do think it has been beneficial for some of our patients that truly struggle with fatigue because we don't have anything to offer them. So just trying to understand how to accept the disease, the diagnosis, the symptoms, and still have a quality of life that they appreciate.
So there's a few questions about disease control maybe that will target a little bit different to symptoms. The first is, maybe I'll take this that I wasn't clear. You tell us normal is normal, yet we seem to be unsure as to whether a patient with an ALP of 1.4 times the upper limit of normal should be on second-line therapy. And I think this goes back to concepts, right? There's regulatory endpoints. I like to think about things as regulatory endpoints of this ALP of 1.67 times the upper limit of normal, and ideal endpoints. For me, I think a normal liver test is what we should strive for. Whether you're going to be able to access therapy for those patients in between is different and will differ by country and by region, right? So simple way to answer that is that, yes, I think normal liver tests are probably better for everybody, but you have to think about the context of the patient, whether normalizing their liver tests is going to improve their outcome in the long term based on comorbidities. But in general, I would say, if you want to be simplistic about the answer, yes, normal liver test is probably best. Triple therapy, there's a question about urso plus PPARs plus obeticholic acid as an option in the real world.
It's
the only
a
one
new
that
point in
has
the
it, so-
U.S.
I will happily answer that. So we use that a lot. In Canada, we still have access to obeticholic acid. So we had published a series of about 50 patients who showed that you do get normalization in a patient's improvement/normalization in patients on triple therapy with a PPAR plus obeticholic acid, despite the order you use of those second and third line therapies. So, it's limited to patients who are truly high risk, right? Those young patients who have ongoing elevations in liver tests, particularly over 200, despite your initial second line option that we have used triple therapy in for. So I think if you have access and the patient is at high risk, that it's not an unreasonable choice as long as you are comfortable and see a fair number of these patients, right? Okay. Will we ever have RCTs comparing Beza versus Ela versus Sela?
No.
So what about cost, right? Bezafibrate is available in many countries at a much more affordable price point. How do you feel about use of an off-label option in such a context?
So I'll say that I can't speak to Beza, because I think it's a little more complicated with Beza because you do have a randomized controlled trial, you have more data there. For us in the US with fenofibrate, we really don't have much data. We were using it sort of because of the lack of other options. But now that we have options of drugs that have been demonstrated to be safe and effective,
Right.
we use that. And I will say that I am a bit concerned about the doses used of Bezafibrate for safety reasons. And when I've used fenofibrate in the past, I start at the babyest dose, like 48 milligrams, because I don't know if it's a class effect or what, but it's, the hepatotoxicity of these drugs seems to be more, it seems to be more sensitive in cholestatic diseases. We saw that with Seladelpar in the early stages of its development. I think with Bezafibrate, if you look at the Bez-Ursa study, the number of adverse events they had was relatively high compared to the number of patients. So we do have to be careful when we apply doses of these drugs that weren't necessarily designed for the diseases we're treating.
There's been some smaller studies using fenofibrate in the US, and there have been decent discontinuation rates because of these adverse events. So my practice is similar now. If someone has been on fenofibrate for a long period of time and has good control, I will tell them that there's approved therapies now, but most of them want to stay on fenofibrate and don't want to change anything. But for others that don't have disease control, I'm not going to start, someone that needs new second-line therapy, I will not choose fenofibrate over two potentially, equally, if not more effective therapies that are now FDA approved. So I'll be using either Elafibranor or Seladelpar.
Maybe we'll do one more question, then we'll end. But just to say, I also agree. I worry a little bit about toxicity too, and I'll say we have access to Bezafibrate, and I rarely ever start someone on full dose. I always start every other day, 400 milligrams of Bezafibrate, and if they're fine on that, they stay on that, and if they're not, and we slowly up titrate and monitor. So the last one is, do you think the mechanisms of PPARs have differential impacts on, say, disease activity and or symptoms?
I think that's a great question. We just don't really understand. Everyone talks about these differential effects of these isoforms of PPARs, but they all seem to have, at least in terms of improvements in alkaline phosphatase, they all are anti-cholestatic. So it's possible there are some differences that we're not able to measure, but so far it's hard to say there's a real differentiator there at this time. I mean, at least clinically.
Tying into the question earlier about switching the PPARs, I think that might shed some light into if you add a little bit of alpha activity, then maybe there's a change there, but I don't think we know the answer yet.
Yeah.
Real world dynamic use, I think, will help understand some of these things. But my approach right now is just to say, regardless of what PPAR you use, biochemically at least, you're probably going to end up with the same result.
So thank you all for joining us. I hope you found it educational. Really important, I think, to be sure that in the patients that need second-line therapies, you really think about implementing it. We know from past experience that getting patients treated that need second-line therapy is not being fully implemented, and so that's really important. So thank you again for your attention.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. To hear the other episodes in this program, Innovations in PBC Care, or to follow along with the slides, click the link in the show notes. And to get access to all of our new podcasts, subscribe to the DeSera Clinical Education Medical Specialties channel on your favorite player. Thank you. See you on the next podcast soon.